very difficult patients to manage. Which kind of the treatment is appropriate for these patients? If we look at these statements, we understand that osteoporosis patients manage is very difficult because of this bone is tendency to break and increase in the bone fractures and others. But approximately 50% in the body is the trabecular and spongious bone. And now, this is a statistics and the National Health and Nutrition Research in the United States. Also, results also show us that, of course, the osteoporotic patients is very crucial to manage and treat and after neoplasm in social. And you know, in biomechanics and the changing and the mechanical properties of the cortical and spongiform bones are different because there are two structures. Spongious is soft and the cortical is hard bone. And the rigid and more, the cortical bone more rigid than the spongiform bone, resistance to higher tension but lower strain before damage. And all these changings and difference between the structure of the bone cause, as a result, a decrease in bone density, increase the brittleness of the bone. When after degeneration and in the osteoporotic spine bone, the load sharing are difference is the changings. For example, in the changing in neural arc and posterior vertebral body and anterior. We compare in two groups. We see that the sharing loads is difference in the osteoporotic and degenerative patients groups and normal structures. To measure the osteoporosis in the whole world is standard and the DEXA and also the classifications for show the degree of osteoporosis and severe osteoporosis. After in the patients groups actually is very difficult to treat in surgery, and after the comparisons that which kind of the instrumentation should be performed for these severe osteoporosis patients. It is fact that the osteoporosis treatment is not only surgery. There is a multidisciplinary treatment with endocrinology doctors, physical treatment doctors, and also neurosurgeon. If we establish this correlation between the three departments, that of course the outcome will be favorable. About the surgery, that in osteoporotic patients, now this is, of course, are known vertebroplasty, kyphoplasty, stabilization with dynamic systems or rigid systems. To evaluate the patients, that we should evaluate patient personally, that which patient is appropriate for which kind of these procedures. For evaluation, McCormick, the classification is appropriate to manage these patients groups. This is a 57 years old that after the comparison fractures because of osteoporotic kyphoplasty, that after kyphoplasty that the patient, of course, the result is favorable. But the before surgery, should the densitometry is a good examination to show that which is need to the instrumentation or not. If the fractures in one level is okay, kyphoplasty is a good idea to treat these patients groups. This is other patients. This is our case that after kyphoplasty, unfortunately, that because that the acrylic caused the fracture after 1 month. And yes, we do the kyphoplasty and also stabilize this inside the vertebra. And after 1 month that the patient came to our clinic with severe pain because of the kyphoplasty caused the split fractures. If we think the retrospective, it's better we should instrumentation by strong this spine. Sorry. Yes. Just now it is clear. To create a strong the screw, and in these groups of patients, that which kind of the procedure is appropriate to create a base stabilization, increase the diameter and length of the vein, and the change screw design, and the others is place screw in B cortical, and increase triangulations, use cements, injectable screw, and use expandable. In fact, if we performed these procedures, what is the reflected to the outcome? Is of course, it is only theoretic, or in practice also can positive affect this patient or not. This is a paper that these authors concluded that after fusion and instrumentations, they studied the patients that the very more complication, that early complications approximately 30%, and late complications is approximately as postoarthrosis 11, and adjacent segment disorder 4% and 25%. Of course, this is not good results. But only rigid fixation that create a good, strong instrumentation and treatment for patient or not. Of course, these results show us, unfortunately, is not good results. The other idea is the instrumentations, that with a posterior instrumentation, because of the pedicle is increased directly into the osteoporotic vertebra without passing the neck. It provides an equal load disruption in the upper and lower end plates. But many authors also define that spiral blade may be alternative to anteroscalar fixation in the osteoporotic spine, offering the same cut-off resistance with one implant rather than two screws. Bicortical, of course, that provide the strong stabilization or not. Bicortical screw, and in this series, show reduced transpedicular screw loosening by approximately 20 and 25%. Of course, it depends that vertebral level and screw diameter and size of type of the screws. The other authors, of course, define that the screw coating by hydroxyapatite, that what is the result? Of course, they concluded that these screws decreased risk of screw loosening problems. Of course, there are many procedures like this, and double screw applications. Of course, this is a cadaveric study that they claim that the single 6 millimeter diameter screw has higher elution rate than the double 5 millimeters screws. That, of course, this is, they concluded that this is effective when you use the two screws. It's effective to strengthen a spine. And also the other authors, just this is our clinic's studies by Dr. Onur Yaman, that kind of the screws, that transpedicular screws redesigned with modified helical angles exhibit higher pull-out strength compared to the classical transpedicular. On the other hand, this study that concluded that the influence of screw length on the peak stress in the screw become negligible when the screw is of a sufficient length to extend it fully into the vertebral body. That our study that supports the kind of the screws, and the others that only the length of the screw inside the bone is effective to strong stabilization. And also the others at the cement injections, that they expressed that the significant increase in pull-out strength, and other there's expandable pedicles, that expandable pedicles screw can be efficacious in case of osteoporotic. And others procedures that we define as Dr. Roser also talk about that is a dynamic systems. Dynamic systems of you can find the more that the finally authors by design Dr. Roser. This is our study, one of my colleagues in phonics, that the biomechanical studies, that in the dynamic study, the share of the load that is coming, that the 50% on posterior and other in anterior. But in the rigid fixations, that the load is coming only, we fix only coming the posterior elements. That it is cause a loosening of screw because the load of the posterior is more than anterior. If in dynamic systems, because of the share of the load, that the loosening and also pull out or breakage of the screws may be less than the rigid systems. Now, I'd like that go together to this patient treatment journey, traveling, because of the study that are very tragic results. This is a 77 years old female patient and come to our L5 vertebra structures. First, we start by dynamic instrumentation. That we perform this dynamic instrumentation, hinged screw and the peak rod, balance G, article peak rod. And after kyphoplasty, between L4 and S1, dynamic instrumentation and kyphoplasty on L5. And after 2 months, come again patient to our clinic with back pain, started 5 months after a while, the patient was very good. MR showed serious impairment at the adjacent segment disorders, you see here, between L3 and L4. Of course, dynamic system extended by adding L2 and L3 vertebra. And this is a other operations, third operations in December. And then the patient come again here, that compression fracture between T12 and L1. And only we perform kyphoplasty to T11 and L1. Of course, the pain relieved and patient came back to home. And then come back again, that 2 years later she was reoperated for back pain and the instrument systems was made rigid and extended to T10. And then after 8 months, it was extended to T3 upon the fractures on the T9 and also iliac screws. This is the patients that start this trip by dynamic instrumentation. First dynamic instrumentation, and they come 4 or 5 operation. This is the other patients that start the journey with rigid fixations. This is the first. The patient operated the other centers, and after instrumentation come to our clinic. And of course, after 3 months of surgery, severe back pain, especially during walking, in increasing. Of course, we extended to upper level because of adjacent segment disorders. And in December 2014, up to T11 road connection was extended. L1, L2 intervertebral cage and fusion. PLIF performed to these patients. And then T10 extended with rod connection to T6 with compression fractures. And we used the connected to extended the instrument. And in June 2015, came again to our clinic with paraparesis because of T6 compression and canal stenosis and compressed to spinal cord. And the right T2 and the left T3 extended using rod interconnections. Of course, this is two very good examples that, of course, it starts with fusion, the outcome and the journey same, pathway same with the other patients that start with the dynamic instrumentation. It is real that if the patients that don't treat too strong